Dr. Francis Collins is the director of the National Institutes of Health, and he's here with me today. And Dr. Collins, you've never been afraid to think big about science, and in your agency, you think it's very important that the research really improve the lives of Americans. How do you think we can keep more in step with research and what else is happening in healthcare today?
Well, that is our mission, to try to understand how life works and then what happens in the presence of disease and what we could do about it. So the NIH has a broad array of research programs, from very basic to very clinical and everything in between. It is a very exciting time right now.
Sure.
We have the ability, because of some of the new technologies, some of them coming out of the Human Genome Project, to be able to identify at a rather precise molecular level what causes diseases like cancer and diabetes and heart disease at a level of precision we couldn't have dreamed of even a few years ago. And that opens up the possibility of personalizing our approach to disease, to be able to, in our prevention strategies, not just do one-size-fits-all prevention, but have it be appropriate for that individual because of their risks.
We've learned some phenomenal things about the kind of technology that is available today.
Indeed.
But will it be available to the average American?
Well, there's the prevention part, there's diagnostics, which is increasingly also personalized. There's the ability to choose the right drug for the right person, and there's the development of brand new therapeutics, but they are very much out on the cutting edge. We need to do several things. We need to continue to press that research forward because, boy, the opportunities are enormous. But we also need to figure out how to implement the discoveries that really work as quickly as possible and not have these long lag times between knowing what works and actually getting it into practice. In that regard, NIH is working closely with a whole network of HMOs that already have electronic medical records. They become sort of our implementation laboratory. When there's a new idea about something that looks like it might work, like a DNA test that would predict whether this drug is going to work for you or not, we have the chance to test that out quickly instead of waiting a long time or maybe getting an incorrect answer. Those kinds of things, coupled with better understanding on the basis of payers about what actually is turning out to be reimbursable, because they're always going to be a little skeptical until somebody proves that this is clinically useful. And, of course, other issues such as regulation. How do we make sure that we have good oversight so that things that are being put forward are appropriately scientifically based? And we have the physician and other health provider educational challenge. This is one that I worry about. I'm a physician.
Yes.
When I went to medical school, we didn't get a whole lot of genetics in our course, and most physicians out there have not had this either. And yet, most providers are going to have to become genetic counselors in the near future. We need to quickly provide the kind of decision support tools they will need to be able to take this complex array of very detailed molecular information and apply it in a rational way that will help people.
So a lot of education needs to be done for these folks that are making very important decisions. Who's going to provide that education, do you think?
A lot of the professional societies are very interested in doing this. I mean, this is part of their goal, is to be sure that they're delivering health care in a fashion that is going to be providing the greatest benefit. Interestingly, I've discovered that it's not just the physicians that want to get engaged here. Physicians' assistants are all revved up about this. So are the nurse practitioners. So are some of the social workers. Because clearly this is an opportunity to enlarge the healthcare team's impact, particularly when it comes to prevention. Prevention, we know, doesn't really work unless you take the time to be able to explain to somebody what they might want to do as far as changing their health behavior and then provide them with some support to maintain that. And that may not be the best job for the busy physician who has 6 or 7 minutes to talk with you. We need to come up with better ideas about how to encourage prevention with a different array of providers. And
in your work at the National Institutes, do you have a priority list of what needs to be done? A step list, step by step perhaps?
The NIH is an enormously complex organization. There are 27 institutes and centers devoted to all sorts of different topics: cancer, eye disease, heart disease, on down that list. Each of them led by a world-class scientist, each of them looking in their field for where the highest priorities are. My job is to try to look across the entire landscape of biomedical research opportunities and make sure that when a new, potentially breakthrough research idea is coming along, that we chase after it as fast as we can, and also that we work effectively with the private sector so that the whole is greater than the sum of the parts. It changes every day, so there's certainly not sort of a checklist that I get up every morning and it's always the same. The job changes so rapidly, but it's exhilarating. There's never been a time of such rapid progress, and to be able to see how that's moving forward and how that's going to save lives is a wonderful privilege.
And I've heard that you've always been interested in science. What's the best part of your job?
I guess the best part is when somebody comes to me and says, "You won't believe what we've just figured out." Well, for example, last week I went to hear a presentation by somebody working on vaccines who showed me the data about how close we are to a universal vaccine for influenza. You wouldn't have to take this every year anymore, and it wouldn't be such a disaster to have a new flu strain appear somewhere in the world because we would all be immune to all flu viruses from this single vaccine. That sounds like science fiction? Maybe not.
Sounds very cool. All right. Well, Dr. Collins, thank you so much for spending the time with us today.
It's great to be with you.
I'm Mabel Jong. You're watching continuing coverage of the World Healthcare Congress in Washington, D.C.